Good afternoon, good evening to those in the East Coast. We're so happy to have you join us today for this live piece of Ask the Doctor. My name is Kathy Molig. She, her are my pronouns, and I am the founder and executive director of Trans Family Support Services. We service trans youth and their families all over the country, and our tagline is navigation for the journey. So whatever might come up for our trans youth and their family, we're here to serve you at no fee. So we're really excited to be able to have this partnership today with Rady Children's Hospital, which is located in San Diego, and the folks from the Center for Gender Affirming Care. I'd like to start out with bringing on Bix, who is going to share a little bit about the center and what their role is.
Hi, my name is Bixby Marino-Kibbe. My pronouns are they, them, and theirs. And I'm the program director for the Center for Gender Affirming Care. I was hired here at Rady back in January of 2019, so I've been here about a year and a half. And prior to that, ran the behavioral health services at the San Diego LGBT Community Center in Hillcrest, which is one of the largest LGBT centers in the country. So over the last couple of years, Rady has really been investing in expanding and kind of transforming gender care services for the young people in San Diego. One of the kind of biggest changes that came with this clinic was creating a position for a director. So kind of prior to joining Rady, we had a couple of physicians who were providing care, but really no additional infrastructure or support in terms of additional services. So a few of the kind of biggest changes that have come over the last couple of years, all new patients and new families who are interested in receiving care here at Rady start with a comprehensive assessment with me. That's an opportunity to sit down and get to know your child a bit better, get to know your family a bit better, and make sure that we're really individualizing our care. It also means that we no longer require kind of outside therapist letters in order to start any kind of gender affirming hormone care. This also allows us to kind of provide additional family support. We can do family education sessions as often as are needed for families to feel like they're moving in the same direction as their children. We have also kind of integrated a new multidisciplinary approach to our care. And so we recognize that that trans youth need more than just hormones and puberty blockers, but there are a lot of different aspects of care that are really important. And so we've been working with folks in our nutrition department, folks in behavioral health. We have started a top surgery program here and have now successfully done, I think, about 10 top surgeries here at Rady. We have integrated now a new adolescent medicine and young adult component, which you'll hear much more about from Dr. Inwards-Breland. So in general, we want to kind of bring all of the expertise that best serves our youth and allow them to receive that care all under one roof in a clinic that is specifically designed to feel safe for trans and non-binary youth. We also are working hard to kind of make sure that not only is the gender clinic a place that young people feel safe, but also Rady Children's Hospital is a large kind of healthcare institution. So we recognize that trans and non-binary folks break their arms. They need appendectomies. There are a variety of different kind of health things that come up for all people. And we want young people and their families to know that if they need to go to the emergency room or they need to visit orthopedics, that they'll be treated with the same level of respect and care no matter where they go in this hospital. So there's been a lot of work done to kind of increase education. Kathy has been a huge support in helping to provide some of that training to different departments here on campus. And then we've started to look kind of system-wide at what are some of the areas where we need improvement. So that involves looking at our electronic health record, making sure that it's up to date and is using the kind of latest kind of best practices when it comes to the collection of demographic information related to somebody's gender identity or sexual orientation. So it's a really exciting time to be at Rady. We're really excited that Dr. Inwards-Breland is here now and looking forward to kind of continuing to expand things.
Thanks, Bix. It's been great having you as a part of the team of kind of revamping the care at Rady. Some of you may know that I have been a part of the journey of Rady and trans care for about 8 years, and I am very pleased to see the changes that have happened over the last year and a half or so, and just the movement forward and the commitment that leadership has made towards those changes. So I'd like to now bring on our doc for Ask the Doc. So Dr. Inwards-Breland is the Division Chief of Adolescent Medicine Division at Rady Children's Hospital. He is the co-director of the Center for Gender Affirming Care and a clinical professor at UC San Diego School of Medicine. Dr. Inwards-Breland is a true Californian. He started his educational career at UC San Diego, which is great that now he is teaching at UC San Diego. He then moved to UC Berkeley for his master's. He received his MD from UC Davis. He did his residency at UC San Francisco. He did for a little while, moved to Georgia, and then came back to California. And after 6 years of working as a pediatrician, he decided to enter into a fellowship at UC San Francisco in adolescent medicine. This is an area of medicine that we in San Diego have been desperately needing for our youth, and I'm super excited that we are finally going to have this division. So Dr. Inwards-Breland was the clinical director of the Division of Adolescent Medicine at Seattle Children's. He founded the Seattle Children's Gender Clinic. He's had numerous awards. He will talk a little bit more about his history with trans. I'm reading is so that we all have the understanding that he comes into this position well-versed in being able to take care of our youth. So in his off time, he enjoys art, spending time with his husband and super adorable daughter, and riding his Pendleton. So without further ado, I'm going to turn it over to Dr. David Inwards-Breland.
Thank you, Kathy. Great to be here. Wow, you can introduce me anytime. So as Kathy said, I'm a native Californian. I'm actually from the Inland Empire, which is kind of San Bernardino area. And as she said, I did my undergrad here. I've always wanted to be a pediatrician ever since I was 9 years old, because I see myself more taking care of young people as they journey through the developmental milestones of youth, and then helping to create healthy, happy adults. So that really spoke to me. And then adolescent medicine also was, I always say it's the last ditch effort to make some changes before they become an adult. And it's wonderful. As Kathy said, I created and founded the Seattle Children's Gender Clinic. And that was a labor of love, mainly because it wasn't very easy to do. I was in Seattle for 11 years, and I came into that job wanting to serve LGBTQI youth. It was really hard to kind of find my way through that process. And I had a really great division chief who said, hey, if you want to serve that community, just say you want to serve, and we'll try to advertise that you're out here. And it worked. I started seeing patients who were gender diverse. And I remember my first patient, I was so happy they were there. I sat them down and said, I have no idea what to do, but I'm going to learn because I want to be able to help you. And really that cascaded into me learning gender affirming care on my own, which, you know, one caveat, I'm changing that. I don't want providers to totally learn this on their own. I want to teach our medical students and residents and so they can feel comfortable being able to see gender diverse youth. And ultimately, I started seeing more and more gender diverse youth. They would come into me and saying, Dr. Inwards-Breland, we're so glad we found you. And I, I'd ask, how did you find me? And they said that, well, my pediatrician just Googled gender diversity in Seattle Children's Hospital and my name came up, which is a good thing. But that's not a really good way to find care in medicine. And I felt that we needed to do something. So I collaborated with some really smart people, researchers, to look at doing a research project and look at the needs of the gender diverse youth in the Seattle metropolitan area and their families. And we published a paper that looked at the key things that were barriers to care in that area. And one of the barriers to care was the patients and the parents wanted to have a multidisciplinary gender clinic. And so we heard them loud and clear. I talked to colleagues around the country. One thing that you'll know is, or you'll find out if you don't already know, the gender affirming community is relatively small, and so we all know each other, and we all always talk to each other and pick each other's brains and don't reinvent the wheel. And so I got some advice on how to proceed. And actually, a year before the gender clinic started, I had Dr. Joe Olson Kennedy and Aiden Kennedy come up and do grand rounds. And they really helped to open the eyes of the community. I was telling them what we needed to do, but I was one of them. And so they needed some outside people to come in and say, you need to do this. And then in 2016, we opened our doors to our multidisciplinary gender clinic. It'll be 4 years old in October. I bet you're wondering why I left. It was really hard to leave. I felt that we had really made a difference in the care of these young people. And by the time I left, we were contacted by about 1,600 families, and we were actively helping with gender affirming care for about 800 families. And so that was a lot, and which I'm very, very proud. But I have a daughter, as Kathy mentioned. She's 19 months old. I have a husband, and we felt that we needed to have some family around to help with her and for her to know her family. And so we chose to move to Southern California, and this job came up. And initially it was just to become another pediatrician in the general peds, but I negotiated because I felt like the adolescents and young adults in this region needed more than just a primary care provider. They need primary care, but they also need providers that know the developmental trajectories of care for these young people. And so I negotiated with Rady's and UCSD to develop a adolescent and young adult medicine clinic and division. We already had 2 adolescent medicine board certified or board eligible providers that were already here, and I was the third. I think it just really melded and came together nicely. And our affiliation with the Center for Gender Affirming Care, it makes a whole lot of sense, because I am trained to take care of patients up to 26. And so are my faculty. And so adding the adolescent perspective along with the endocrinology perspective and along with social work and social determinants of health, it really melded our Center for Gender Affirming Care to be multidisciplinary. In the adolescent and young adult medicine clinic, we will see, I'm the main provider that will see our gender diverse youth, but I'm training my faculty to also be able to see them, because one thing that I noticed, and I took note in Seattle, I had to train more people because more people needed to see these patients. Our access was really high, and we needed to get patients in and out for their care, and so I had to train folks. So I want to train my faculty, but also I want to have residents come in and learn how to take care of patients. And so with us being part of this, we are able to do contraceptive counseling, menstrual suppression counseling. Our two providers can put in long-acting reversible contraception. That's called LARC, which is a Nexplanon and an IUD, which is now a viable way to stop menses. We could do uncomplicated depression and anxiety as far as medical management. We could do ADHD, but most importantly, we can continue to take care of this patient population well into their mid-20s, which I think is key. I think the last thing that I want to focus on in telling you more about me, I go by he, him pronouns. I'm a cisgender African-American gay male. And so I bring into my practice intersectionality. Intersectionality takes into consideration all of the patient, all of the parents, what makes them them, and how that affects their health and how that affects their treatment plan. I think that's truly important. And I think one thing about adolescent and young adult medicine, that's how we were trained. And so my other two faculty are just as versed in that intersectionality piece. To end about me, I have lived in the state of California most of my life. Having come back, it seems like it's full circle. I'm able to take what I learned in school, in residency, as a faculty member, as someone who created a gender clinic, and bring those services here in the San Diego area. And I'm really proud to be able to do that because I think it is something that it needed to expand. And I think my job now is to work with Bix and work with Dr. Marenkovic and work with our other faculty to expand services.
Awesome. Thank you for that. So I have several pages worth of questions that were pre-submitted. So we're going to kind of dive in. And before we do, I want to reiterate this piece about it being adolescent medicine, because I think this is a new thought for many of us in San Diego, that piece of being able to have continuity of care for our kids when they go through what can be very challenging of that bridge from teen to young adult. So that's amazing. And that this is full comprehensive care now that it's adolescent medicine and not just being seen in the endocrinology clinic. So very excited about that. So you shared a little bit about your history in caring for trans youth, and we appreciate that. What is the one thing that has surprised you in working with this population?
I said I wanted to be a doctor ever since I was 9 years old. Medicine is hard. Medicine's difficult. Compliance with medication treatment plans can be really tough. There's a lot of different reasons why maybe patients, families aren't very compliant, and I understand that. But I can tell you that working with the gender diverse population, they are super informed. Our patients know about the medical management. They are engaged in their treatment. They are, and I think what I'm surprised about is how happy I am as a provider in medicine, doing this day in and day out, and how happy I am with my job.
That's awesome. That's awesome. All right, so we have a few questions that are specific to Rady. I know we have people watching either on Facebook or YouTube, or maybe watching this recording, that aren't here in San Diego. So I'm going to kind of go through these, but even as we share these things that are specific about the care here in San Diego, for those of you that aren't living here, you can take this information to the people who you are working with in your own cities, and share this video out and share this information out and contact us, because as the doc has already said, most people who are doing this work as professionals all know each other. I all know who the doctors are across the country. You know, when my son started his transition, there were 3 clinics in the country, 3 trans youth clinic, and now there's over 50, right? So we know who those folks are. Okay, so what's in this age of COVID, right? Lots of surgeries and procedures have been put on pause and deemed elective. We know that word can be very challenging in this community. So what's happening with those things that were on hold, and what might happen as we now see an increase of COVID cases? Are we going to go back to those things being postponed, and are you just doing virtual visits?
That's a great question. I'm going to answer the second part because I think about COVID and what could change. Well, I think in this short period of time, we've learned a lot about COVID, and we've really rallied in protecting our patients, our staff, our doctors, in preventing spread of COVID. And I think also we've learned that cases that are important and are deemed necessary should not be held back. And so to answer, so I don't think that's going to happen. I don't hold me to that, but I know you have an advocate in myself, Dr. Marejkovic and Bixby, that we would do our best to make sure that doesn't happen within the Rady system and UCSD system. But going back to your first question, I'm pleased to say that we've started doing intakes with Dr. Gosman, who's at Rady's Plastic Surgery, and they are actually doing a case a week. Unfortunately, our waiting list is pretty long, but we have gone back to doing those assessments and those surgeries.
Excellent. Thank you. With this telemedicine world that we're all living in now, what do you see as a benefit or a hindrance for trans kids getting the care that they need?
Yes, that's also a great question. Let me tell you, you cannot take telemedicine away. Because it's too late. We know COVID, that's another thing that COVID did for us. It showed that we could still do some really darn good healthcare with telemedicine. And I think that that'll expand reach of patients, because access can be an issue with patients living 50 to 100 miles away, trying to get their care. And so having them not needing to come in as often as we had been dictating before is a benefit and a use of telemedicine. I would say that in starting the process, even the first visit can be under telemedicine. When a patient is nearing the time to start hormone treatment or care, medical care, then they would need to come in. But subsequent visits definitely can be made used with telemedicine. And so I think it's a great thing that we're able to use that type of service to our patients. I envision our clinics to be kind of a hodgepodge of patients who want to come in and see the physician, and then those mixed in with telemedicine visits. And we are now gearing up to make our clinic in a way that is able to support that type of process.
That's great. And I'm so glad to hear you say telemedicine's going to stay, because I do think that it serves a population of our trans youth in particular. You know, I work with families and trying to help families understand that sometimes when they're trans kids, what they would deem as isolating and withdrawing from life, right? They're really just, I try to help reframe that they're just cocooning. There's this transformation trying to happen. And let's be grateful that they feel safe doing that in your home. And so not having to go out to see the doctor, not having to go out to the therapist, it just really helps sometimes for the mental health of that youth. So that's great to hear. Yeah. So I have a question that's a very specific. A family here in San Diego that has been receiving care up at Children's Hospital Los Angeles. They have the doctors with experience of 15 and plus years there. You mentioned, you know Joel's and Kennedy, you pulled them up to Seattle. Are you going to be coordinating with them at all? Will you offer some of the same services? And what about coordinating with colleagues across the country?
Yeah, great question. So I have 10 years experience of gender affirming care. I think the long and short of it is we all collaborate. We have the WPATH, which is the World Professional Association of Transgender Health. There's the US path of that organization. I often will email different folks because different folks are doing different things, and that's okay. As far as collaborating, I don't know about collaborating. I think we all are collaborating, particularly when we share information, share ideas, share medical advice, things like that. As far as doing some of the same things, one thing that I did learn in my journey is that people around the country can do it a little different. And part of me says that that's okay, because each family, each patient will identify with a certain way things are done. And I think that's key. You can individualize care with the different programs, but also there's a lot of things that we're doing the same. And so there's no really need to coordinate. As far as like research and furthering, our evidence on how to take care of patients, I would love to continue to do that in the future. But clinically, I would say that we tend to curbside each other, but no formal process. As far as are we going to do the same thing? I would say about 90% of the time we're doing the same stuff. It may be different tweaks on it, but again, I think Joe Olson would also, and Kennedy would say that she also individualized the patient. So even within our patient panels, it might look a little different because of how comfortable the parents are, how comfortable the patient is, et cetera.
Excellent, thank you. Just for those of you watching and posting questions, I see your questions. I'm going to get them worked into the questions that were also submitted with the folks that pre-registered. So know that we will get there and we promise to get them answered. I have a question that's, again, the last two that are very specific to San Diego, and then we'll move on to medical transition questions. So, what's your first assessment of the state of gender affirming care culture here in San Diego? What can allies do to improve that culture? And what is it that frontline healthcare providers need to know in order to improve that culture?
So I would say I'm going to take a back seat on that because I'm so new. I just got here. And so I have not really, I can't speak to the whole culture of gender affirming care. I would say that I'm in a love bubble with working with Bix and working with Maya and working with folks that have made the gender center come to fruition. And so that's been wonderful. So I can't totally speak to that. It seems great to me, but I think that's not fair. to say, oh, things are good. Things are good. I don't know. But I will know probably in the next 6 months to a year for sure. As far as allies, you know, one thing that I think being an ally is to speak up. You speak up when someone has questions about gender diverse folks. They may do something wrong, but in a nice way, in a supportive way, educate them, because it always starts with education. A lot of times it's just a lack of knowledge. They may say something, they may do something, but educating them in a really calm way goes a long way. As far as healthcare providers, knowing to ask about pronouns and names and using them, that's key. The other thing is if you mess up with names and pronouns, apologize and move on, because if you dwell on it, that makes things worse. So I think that's important. And the same thing with healthcare providers speaking up. You know, if there's a question, particularly if you're an ally, educate the people around you about how you do things. And if you're not sure, you know, there's a lot of resources to get those answers. But I think speaking up and being vocal is, I think, the key thing in both of those areas.
Awesome. I'd like to bring Bix back in for a minute so that we can have the two of you kind of discuss a little bit about what this interdisciplinary care team really looks like. Bix, I know when you came on, it's just such a difference of having someone first that identifies in the community as a part of the program, and second, a mental health provider as a part of the program. So do the two of you want to kind of take a couple of minutes to talk about that?
Yeah, why don't you start, Bix, and I can kind of...
Yeah, so I think one of the first things that we really heard from the community, and I think it's important to say that this process of kind of transforming the clinic at Rady and the services in general at Rady has involved a lot of community input, a lot of input from folks within the Rady system, craft this into a clinic that's going to fit best for the families in San Diego. But I think one of the first components was integrating that mental health piece. So I think a lot of families felt like it was really daunting to have their very first appointment be in an exam room with a physician. You know, as a trans person, I know how dysphoric it can be to sit in an exam room and wonder what's going to happen in the appointment. And you know, that's not always the most ideal way to kind of first step foot into a space that's going to be kind of an ongoing space for you to receive your care. So I felt like it was really important that young people could sit down and really talk about what their expectations were for care, families get some answers and feel like, this was a really thoughtful and comprehensive approach in a space that wasn't going to do harm and that was going to really feel affirming, and where kids could leave there feeling like, hopeful about their gender journey. We have ongoing challenges with long-term behavioral health. I think that's across the country, but we feel like it's really important for our patients to be able to see therapists who have a high level of expertise in gender identity, and not just to see therapists who are open. And so there's a great group of therapists in San Diego, and we work really closely with them and work closely to match patients up with a therapist who not only takes their insurance, but who we think is going to be a good fit. Then we kind of wanted to expand outwards and look at what expertise is under this Rady umbrella that we could really tap into. And with our kind of gender expertise, how can we kind of work together to meet some of the complex needs that come through our door? Because we work with young people who have needs that are beyond, just hormones or just puberty blockers. I think a good example is some of the young people we work with who are on the autism spectrum and need very specific things related to their care, so that they can feel heard and so that they can feel like their gender journey and their gender goals are really understood. And so kind of a next wave of multidisciplinary care has been working closely with our developmental assessment folks and really kind of pooling our knowledge together to make sure that we're connecting young people with services, so that they're not also having to chase down 1,000 different referrals. Mm-hmm. A couple of other kind of parts of our multidisciplinary, we've been working with the speech and language pathology program. We have a couple of speech and language pathologists who work specifically with trans youth around voice dysphoria, and our young people who have tried that service out have had really good results. And then, the plastic surgery component. So doing top surgery here at Rady was a big goal of mine. As somebody who had top surgery done in an outpatient clinic, I know how rushed it felt to feel like I had to travel a long distance to have my pre and post-operative care, but I also had to get in the car and come home the same day. And really wanted to make sure that our patients could have the experience of having surgery in a hospital that is, provides expert care and working with young people. And so far, those results have been really great, and families have been really happy to be able to have that kind of additional supportive care.
And then to add to that, you have the adolescent medicine specialist coming in to see these patients. I don't have to repeat, I would say 99% of what Bix has already talked to them about. I can use my time better into really assessing some of the other things that make up an adolescent and young adult. For example, are they sexually active? Do I need to screen them and talk to them about safer sex practices? Do they have an eating disorder? And is the eating disorder interfering with their life in a way that needs to be medically managed? Do they have depression and anxiety? Could, they see this doctor that's not a psychiatrist, maybe they'll be more willing to maybe consider medications and getting into therapy. And so I'm able to do in my hour that I spend with them for their first assessment to talk about other things. Like when in other models, like how we had it at Seattle Children's, I would have to do all that in a 60-minute visit. Some of the stuff that Bix is doing and the stuff that I would be doing, and you can't get through all that. So that's the beauty of the multidisciplinary nature of this process. The other thing about the multidisciplinary nature is we talk to each other. No one, we're not these silos doing our own things. We talk to each other, and we individualize care for each and every patient and family. And I think that's some of the beautiful pieces of it. The other thing is, as an adolescent medicine specialist, we have a way of interviewing. We do something called a biopsychosocial model interviewing, where we talk about everything that could affect a young person's school, education, activities, diet, drugs, sex, rock and roll, all that. Whereas other specialties don't really go into that. And so really having adolescent and young adult medicine part of an interdisciplinary team for adolescents and young adults is crucial to me, because we can actually expand and give more resources and services to these patients.
Awesome. Thank you so much. Thanks, Bix. We appreciate your input to it. Now, I want to dive into the questions that are really medically based about transition, right? Mm-hmm. Let's move away from the local kind of thing about the clinic and really look at this. So mm-hmm. At the beginning, what age does gender dysphoria usually start?
Well, there's a spectrum. As you know, not everyone will have gender dysphoria. And to be on the record, I really don't like the term gender dysphoria, because it's really it's a medicalized term. It's a psychiatric term, but it's what we have, and it's what we are able to bill. But I can answer that question to say developmentally, a young person, assigned male, assigned female, could tell you if they are, quote unquote, a boy or a girl. Now, again, this process of identifying of who they are and really seeing themselves in that, it's based on modeling and mirroring from their environment, their mother, their father, etc. And so sometimes, and I would say most of the time, there's young people that don't have that modeling or mirroring of somebody that they would normally identify with, somebody who's non-binary, someone who's gender diverse until they're older and learn the terms and the and know that it's a quote unquote thing that people can identify with. I've had patients say that. And so I would say, as far as gender dysphoria, I would say most prepubertal individuals, because their bodies have not changed, they don't have as much gender dysphoria. But once their bodies start to change, they start to go through the unwanted pubertal development. That's when a lot of the dysphoria comes up. And that is going to be different for everybody. Generally, assigned females at birth, when they go through puberty, it could be as young as 8. For assigned male at birth, that when they tend to go through puberty, on average, it's a lot older. So 12, 13, 14. So it's going to look different. So you can't really use age as a guide to when it's actually going to start. So it really depends.
So that leads us perfectly into the next question, is if you had been reading my notes. At what age or development do we start a medical transition? When do people need to pick up a phone and see a doctor? And can you tell us about blockers and when those are started?
So my thought is, if a parent has a question and want some answers, pick up the phone and call your pediatrician or call us, because I think we could be a resource for patients and parents. But I would say, as far as medical management, is going to be different than those who aren't desiring medical management. So, oftentimes young prepubertal folks who have not started puberty, social transition happens, how they dress, their name, how they cut their hair, things like that. And that's going to also depend, but they're usually prepubertal. And for many of them they're not in their teenage years. As far as medical management, that's going to depend. So if you're looking at pubertal blockers, we tend not to block puberty until it starts. And so we don't block puberty if it's not there. So typically, assigned males at birth, they start puberty once their testicles start to enlarge, and we have a way to measure that. And then for assigned females at birth, breast development is the hallmark of when puberty starts. And so there's this stage. It's called Tanner staging, and it's 1 through 5, and it helps us providers and helps us educate patients and families where they are in puberty. And so typically we start pubertal blockers at Tanner stage 2, which is the first sign of puberty, depending on your assignment at birth. And then as far as hormones, we tend to do peer congruent. Most providers around the country tend to do peer congruent transition. So we know the typical ages when assigned female and assigned males go through puberty, and we try to mimic that. Technically, an assigned female can start their menses at 8 or 9 years of age, maybe a little older. And so typically, an assigned female at birth who is masculine, their peers aren't going to be masculinized. So that's where pubertal blockers really take effect. And then for assigned male at birth, it really depends. Assigned male people at birth, they start puberty later, but they can go through puberty a lot longer. And so someone who's coming in, who is assigned male, wants to be feminized, who their voice hasn't dropped, they're not shaving, they haven't gone through their growth spurt as much. They're growing, but they haven't really peaked in that. Could be a candidate for something called block and replace. And that's to use pubertal blockers to keep them from progressing any further and replace the gender affirmed hormone like estrogen. So that's a complicated way to tell you that it really depends, but there are some hard stops. We don't typically start pubertal blockers until patients are in puberty. And there's some ages around that, but we tend to do a physical exam or blood test to prove that they're in puberty. And then the other times, it really depends on where they are in their pubertal development.
Thank you. And it's that piece that as a parent of a kid, we want to hear hard and fast. It's this, and this, and it's not hard and fast, right? And that makes our job as parents who are newer to this information, and we're trying to process it all and understand and be educated when there's not a definite trajectory. So case by case basis.
Yeah, I think that's a good thing that it's not hard and fast.
Yeah,
because
absolutely.
Everybody is going to be different. And so you need to recognize that. And that's okay.
Yeah. So our next question is, can you briefly share any long-term effects of cross-sex hormones?
Yes. So unfortunately, we do not have really long-term studies. I think some of the studies that we know of are from our colleagues in the Netherlands, who looked at more about mental health and quality of life. So we know in studies from them that patients who are affirmed, they're socially transitioned, they are put on pubertal blockers and then hormones and then future, gender affirming surgeries, that their mental health actually improves over time and their quality of life goes up. We don't have those studies here in the United States, but there was a study a couple of years ago that looked at the kind of biomedical markers like blood pressure, any risk of diabetes, things like that. They looked at a subset of youth who were gender diverse and followed them over a year. And we do know, if we look at testosterone, that testosterone does increase blood pressure, but rarely, I would say I've never seen it causing high blood pressure. But as they get more muscle mass, you need more oxygen carrying capacity, and so blood pressure goes up. Their red blood cells go up too, because that's what brings oxygen to those blood vessels. So that's going to go up. Also, we know that testosterone lowers the heart protective cholesterol, so that puts them at risk for heart disease, but their risk of heart disease is not higher than a cisgendered male. I would say overall, looking at testosterone, it's pretty safe. Estrogen, I think the same thing. It's very safe. I think the main thing that we always worry about is the formation of a blood clot, because some estrogens can do that to some people, and those people who are more prone to developing blood clots that can go to their legs or their brain or their chest have a high risk of that. The general population, we don't have that as a marker. I would say the general population that don't have a risk of blood clots is about 1% to 2%. Someone who has a high risk of blood clots, family history, is probably closer to 10 to 20%. So the risk of a blood clot is super low. The other thing that we do is that we tend to use a form of estradiol that is less prone to cause blood clots than what's in something. For example, what's in the birth control pill. They've done studies that show that what's in the birth control pills, even though the risk of a blood clot is low, it's still the estrogen that we use is even lower than that. So that's another thing. Also, long-term estrogen can affect some of the cells that are in the testes that produce sperm, and so it can predispose someone to infertility. So we know that. We also know that giving hormones can predispose people who are predisposed to diabetes, have the higher risk. But in the 10 years that I've been doing this, I've never seen any of our patients ever go into frank diabetes or have high blood pressure, etc. There are some other things, but I think what we desperately need, and I think there is an NIH study out there that is looking at patients over time in their biochemical nature, markers, things like that, to see what happens as they reach adulthood. But unfortunately, longer term studies are still lacking.
Yes, yes, we're very grateful for the NIH studies, and I think a lot about parents 10 years from now that will have this information and feel a little bit more comfortable in their path than what those of us that have been doing this without any of those studies have felt like. So we have a question about those that are taking estradiol and a testosterone blocker. What about adding progesterone?
So I'm all for that. Me personally, when I started prescribing progesterone, most of my patients had some mood issues, and so I talked to some of my colleagues around the country, and a lot of them started once they patients have been on estrogen and do not see any further effect on breast development, and that's really where progesterone could be of value, is further breast development, further contouring of the breast, etc. So I tend to have patients start the testosterone blocker, estradiol, see their progression. Once they say, it's been months and I've not seen any progression of their breast development and they're at their max doses of estrogen, that's when I will again talk about progesterone. I tell them at the very beginning that that's something that we could actually use. But I tell them at that point that we could use that as something that could augment some of the development. But again, it is out of the three, it's probably the one that probably has more side effects that I've seen with some of our patients. And I typically, and this is what I do, I typically tell patients that if they take it and they start having some mood issues, to stop it. And it's okay to just stop it. To stop it and then give us a call. If they're doing fine, they continue it. I see them back. If they're continuing to see breast changes, I keep them on it. If they stop seeing breast changes and it's been a few months and we've not really seen much change, I have them stop it, because that's just another medication that they're on that's probably not doing anything. And so we just put it towards estrogen and spironolactone or something like that.
Awesome, thank you. There's so much emphasis for our youth around chest, right? So for our folks that identify on the trans feminine side, for our folks who identify non-binary, for our folks that identify on the trans masculine side. So we're going to talk a little bit about top surgery for our trans masculine folks. So there's a lot of issues that I see in our work with families. Like, a lot of times families like blockers, they understand, they meet with a doc, they get that. Even cross-sex hormones, they meet with the doc, they understand that. But the surgery piece tends to be something that as a parent can be extremely overwhelming. And as you said, your patients are coming in, these kids have done all their research. They knew who the best surgeons are in their area. They know what all the different procedures that are there. Like, they come in like everything. So questions we have from parents are, and I'll start with just a couple and then do a couple more. What age are you referring for top surgery? Is there an age limit and requirement? And what should one person expect leading up to surgery and post surgery?
Okay, so I try to stay away from an age because, as I mentioned before, peer congruent transition, puberty can look many different ways. a patient could be the same age and there's 3 of them and they all could look different. So it really depends on the best estimate of when the chest has stopped growing or stopped changing. Now I could tell you that developmentally, if you physiologically, the breasts kind of stop changing around 14, 15, but that's not going to be everyone. Okay, so it really depends. And so I tell my patients, if they want to talk to a surgeon about top surgery, I don't care how old they are. They should be able to talk to a surgeon about it and what it's like, and really get more information about it. And so typically, most surgeons will have the same thought process that I have, is that they want to make sure that the breast or the chest has stopped growing. And so that's one thing that they will evaluate. I often tell patients, what to expect. If they're going to have top surgery or bottom surgery, that means may mean a physical exam, and that may mean someone taking a look and giving them that heads up, so they're able to know, okay, this is going to happen. It's not going to be a surprise. I'm gonna go in it head first and do the best I can. And so we talk to them about that. We also talked to them about asking, and this is what I ran into issues in Seattle, where some surgeons will require patients to be on testosterone, which we know that WPATH is not, basically someone who is non-binary, who doesn't want to be masculinized with hormone, but do not want their chest, should be able to get their surgery. But some surgeons want them to be on testosterone, so we talked to them about that. Also, some surgeons want them to stop their hormones or their testosterone pre, during, and a little bit after. And I looked at the literature. I don't find a reason to do that. And so I empower them to really press their surgeon to say why. And maybe that's not the surgeon that they should go with, and maybe look at other surgeons' practices. The other thing is, it's always nice to have support. Talking to other patients about how it went for them, having parental support, having staff support, if they have a therapist, having those support, because there is a small risk of decreasing mood or post-surgery kind of depression that I often tell patients about. And so I forewarn them that could happen. Oftentimes they're super happy, they're really ecstatic, they're really great at I had a patient, come in, it's like, yeah, Dr. Inwards-Breland, I had top surgery and went like this. And I'm like, oh, okay. All right, thank you. Yeah, I'm glad that happened. But they're really happy with the outcomes. The other things that I tell them is that the surgeon will dictate their recovery period, when they need to come back, what to expect, when they'll be able to lift up their arms over their head, things like that. The surgeon will dictate that. And if they don't understand or they didn't get everything, ask for it in writing, because oftentimes we as physicians will give them a lot of information, and some of it goes in one ear and stays, and some goes out in the other ear. So get things in writing, I think, is another piece of advice that I tell them. Let's see. And then let me also just say, if for patients who are looking for breast augmentation, there still is no evidence to actually stop estrogen treatment. The risk of blood clot during surgery or after surgery is still really low. So that's a conversation that I think our feminized patients should have with their surgeon about that practice. Because I think one thing that we are trying to educate surgeons is that, them stopping their hormones, it could be very dysphoric, or they can really, mood can plummet. And we want them to be in a great mood for a surgery like this. So I'll stop there.
Awesome. I love this piece about any youth that is considering should be able to have access to the surgeon.
Mm-hmm.
You know, I'm a big proponent when I'm working with families of get your education. You know, parents tend to want to make decisions based on their preconceived ideas rather than from actual facts. And so that, like, you know, if you're 12 or 13 and this is something you're thinking about, go talk to a surgeon, right? Yes. And I just want to add a little note to parents about insurance. Like, don't let your insurance dictate your child's care. You know, that's a big piece of service that we provide, is helping people fight insurance denials and stuff, but insurance should not be dictating care.
The other thing that I want to add to that is don't wait until the last minute either.
Yes, please.
Don't think, okay, now I'm going to seek gender affirming care, or I'm going to gender affirming surgeries, and I'm going to try to plan it for the summer. No, it doesn't work like that.
Right.
You need to plan. You need to plan it for, it could be up to 6 months to a year.
Right. Or my favorite is the families who, you know, well, we're gonna do top surgery over the holiday break, and they're talking to you in like October or November, and you're like, first of all, no surgeon has availability like that. And perfect. So 2 more things quickly on top surgery, and then we're going to move to our last topic. Are there any indicators for not referring to top surgery? And the second one is it important for one to build up chest muscles prior to having their chest tissue removed?
I don't know of any reason why someone shouldn't be able to talk to a surgeon. I don't know that. If anyone out there knows of a reason, please let me know. But I don't think that there is a reason why someone shouldn't be referred. Now, when they refer, if someone is actively suicidal, actively depressed, that they're not functional, maybe they need to help get that a little bit better before they go talk to a surgeon, only because I want them to be able to understand everything about the surgery and the next steps. But ultimately, I don't see a reason. And then what was the second question? I'm sorry.
It was important to build up chest muscle.
Oh, yeah. I would say, I don't know if there's I don't think it's important to build up chest muscles, only because anecdotally, most of my patients aren't very active.
Yes.
and a lot of our patients don't actually build up chest muscles before the surgery, and they have just as good as outcome. So, and really it takes a long time for muscles to develop. And so I wouldn't wait for them to develop before you actually get the surgery. I think the surgery is probably more gender affirming and needed before the muscles, because the muscles can happen over time. Yeah.
Great, thank you. So those of you that put comments in the live section, I think we've covered all of them. This last topic, I feel like I left the really big one for the end, and we're almost out of time, but I think you can probably condense it down. But we, a big thing I see with families is, what if they change their mind? And what's the frequency of detransitioning, which is the term that's Google term, if you will. How many kids outgrow it? Is it a phase?
Yeah.
What can you tell us?
So I would say that one, it's not a phase. I would say that we don't have exact numbers because we don't have measuring these throughout the country. And I think that's something that we should be having more information on. I would say that anecdotally, patients that I've seen over the 10 years, I've seen a lot of patients, and I've had maybe 3 patients choose not to be on hormones, but they did not change their identity, their gender identity. I would say that 1 actually felt more non-binary versus binary, male or female. But the other important thing is that those who actually stopped hormones, they didn't regret what they did because they were able to get some benefit from it. So I wish I could give you the frequency because I would give you a number that we don't really know. But I could tell you in, my practice, probably Jo Olsen Kennedy could tell you in her practice that there's a few, but none of them, at least from my point of view, have regretted what they did. I would have to, an example of a patient who probably that would exemplify this is someone who's on the autism spectrum, okay? A lot of people say, oh, it's trans trending. It's just trying to be like the other people. Well, someone that who is on the spectrum of autism, they don't typically go with fads. They don't. And we see a fair number of patients who are on the spectrum who have gender identity that's separate than what they were born. So to me, that was like, wow, okay, yeah. So I think adolescent and young adult is a time of exploration and changes, but I can tell you that the majority of folks choose not to be in a group that is going to be discriminated against or even have violence put on them. So that's another piece of the puzzle that kind of dissuades or helps families understand that this is it's not a phase. I would say there's some developmental trajectories that may change, but overall the identity is pretty consistent. There.
Awesome. As a parent, we're told by you and experts in the field that our job is to follow the lead of our children. And that's a really hard thing as a parent to do. I know your daughter's, very young. Let's talk some more when she hits like 5 and 6. Much less when she hits 12 or 13, right? And honestly, following the lead of an adolescent when they're telling you something that's so far from your concepts of what your child could possibly be experiencing, it's a heavy load. And we know that it is for parents. And that's why, our organization is here. That's why we partner with doctors and mental health providers and provide support and resources around this, because we know that it can be really challenging for families to go through. So I want to bring Vix back in if we can and just say thank you so much to both of you for the amazing work that you are doing to serve our youth here and to help grow the competency of serving trans youth in medical facilities. I'm honored to get to partner with you. And for those of you that are watching, reach out to us, reach out to Rady's, reach out to these amazing individuals. We're all here to serve and to just really help one family at a time to move through this gender journey. So thank you all so much, and have a great evening.
Thank you.
Thank you.